Hi, my name is Russ Swallow. We're going to talk about Medicare, and most people find themselves here when they first get started. Now, some of you folks here are already on Medicare, so it's really going to be a refresher course because we're going to cover every single step along the way. And as you know, there's a lot of moving parts. And when I asked about how many people understand Medicare, there's one person that went like this. So it'll be a good course for everybody. Now, if you're already on Medicare, we'll have a section at the end here that gives you an idea of what you need to be looking at. You've got a cheat sheet here on Medicare. It's a good thing to look at afterwards because maybe it'll bring to light some of the things you discovered as we go along. I'm a retiree dropout. 7 years ago, I had this, and they told me to get rid of the stress. So I sold my business. I had been a group health insurance and benefits broker for a long time, pushing 50 years. So then I was retired, but my first day in retirement, I got a Medicare summary notice. And I said, yeah, this is health insurance. This is what I have now. So I pulled out my Medicare card. It's health insurance. So I have some qualifications. I'll just run through here on the screen. And I've had some health challenges. A number of years ago, I had a detached retina. I've had prostate cancer, the radiation won, the cancer lost. I've had this quadruple bypass. And this year I was looking around for something else to do. So sometime in February, towards the end of February, I had trouble breathing. So I went to the emergency room, they put me in the hospital, and I had fluid in my lungs, legs, and feet, which triggered atrial fibrillation. So now I got something else to work on. So they got the fluid out of my system, and they put in a pacemaker defibrillator. So I really know how to use this insurance, believe me. So I reinvented myself as the Medicare advisors and got a new t-shirt. I also have a radio program on Wednesdays from 1 to 2, WCRN 8:30 a.m. I'm going to be on vacation next week, so they're going to run the session I had this week. And the format of the program is I have interesting guests each week. Nobody wants to listen to me talk about Medicare for an hour. So Wednesday I had on the gal that runs the Shrewsbury nursing home and rehab, and I had another one who, told everybody about home health care. And I didn't realize it, but I learned then that they have respite home health care. Because when I was taking care of my mother, when I needed respite for me to unwind, she went into a nursing home for a week. But I learned that there's respite home care now, and Renee knows her, the one who talked yesterday, was Lynn Alexandrowitz. Yes. Did I get that right? Yeah. Okay, so now, since we got a bunch of moving parts, how do I kind of get your attention to say, hey, what we just talked about is over. We're going to start something new. So this is my pride and joy. And what I want to do here now is start with a brief history of Medicare. It didn't exist until 1966. There was none. On the next slide, I'm going to show you the first application, which was pretty simple. Do you want the insurance? Check yes. If you don't want the insurance, check no. And the first monthly premium was $3 a month. And there's the application, and you can see who was the first person to apply for it. It was Harry Truman. And the signature underneath his witness was Lyndon Baines Johnson, and there's a picture of the signing ceremony. Initially, it's hospital insurance and medical insurance. Medical pays for physicians and outpatient. So it stayed that way for 40 years. There was no drug coverage until 2006. Here's what the card looks like today. Hospital is called Part A, medical, physicians and outpatient is Part B. Now, what I try to do here in this discussion or workshop or seminar is Albert Einstein had a great saying. He said, if you can't explain it simply, you don't understand it well enough. So rather than just dump jargon on you folks, I try to tell a story that covers just about all the moving parts you need to know. So we start with how and when do you enroll, and what if you're still working? Well, you can get it before 65 if you've got some health conditions. Normally it starts at 65. You apply through Social Security. You can do it online, or you can do it by phone. If you want to go to the local office, don't go there unless you have an appointment, or get there 45 minutes early. Otherwise, it's going to be bedlam. And what you want to do is sign up for Parts A and B. You got a 7-month window to sign up, 3 months before your birthday, and 3 months after. However, don't sign up 3 months after, because if you sign up in the 3 months before, it starts the first of the month in which you turn 65. If you sign up in the month you turn 65, it starts the next month. But if you start a month later, you got to wait 2 months for it to take effect. And if you start 2 or 3 months later, you got to wait 3 weeks for it to take effect. So even though people think this, I got 7 months, no. Do it in the first 3 of the month you reach 65. This might change next year. We don't know yet, because sometime October, November, we get all the changes that are going to occur. And you need that card, because that card is the ticket of admission, I call it, to get one of the supplemental plans. And yeah, but what if you keep working? Well, we're going to cover that in a bit, but you're not going to get hit with any penalty if you're still working and covered by a group health plan. There is a penalty if you don't sign up when you're first eligible. It could be 10% of every year you were not covered by Part B for the rest of your life. Now, I spoke at an assisted living facility on Wednesday, and there was this nice lady there. She's 80 years old. She had never applied for Part A or Part B. So she gets 15 years at 10%, so she pays 150% of her Part B premium for the rest of her life. I just hope she doesn't shoot me, because I'm the messenger. I didn't create the plans. Anyway, but it doesn't apply if you're still working and covered by a group health plan. What if you missed the 7-month window? There's a general enrollment period from January, February, and March, but there's going to be a coverage gap because the plans won't go into effect until July. And that gap might disappear next year. We don't know for sure. So I picked a Medicare Advantage plan this year, and next year I want to change to another plan. You can change during the annual election period, October 15th to December 7th, with the new coverage to start January 1st. So what if I change my mind after December 7th? So on December 8th, either my barber or hairdresser said, yeah, that plan is not the right plan, and you got to realize both of these people are eminently qualified to advise me on Medicare. So I decide I want to change. So I can change my mind again in January, February, or March. And you don't have to remember all of these. All I'm trying to say is, you're not locked into something forever. You can change your mind. What if your circumstances change? You move. There's 27 different separate enrollment periods. And if a person is out of that original time frame, we try to find one of these that fits them. What if you're still working? Remember I said you can sign up later? When you sign up later, you'll need to sign an enrollment form, and your employer will have to certify that you've been covered by the group health plan during the interim, from the time you reached 65 till the time you retired and came off that plan. I can email those forms to anybody that needs them. Now we're going to hit on the basics. Original Medicare is Part A and Part B only. Hospital coverage is Part A. Medical, physicians and outpatients is Part B. And since 2006, there's a Part D drug plan. Now, somebody always says, where's Part C? Part C is called Medicare Advantage. It includes A, B, in just about all the cases a prescription plan. So Part A has a hospital deductible for each benefit period. Benefit period starts when you're admitted and continues after you've been discharged for 60 days. It's conceivable a person could have multiple admissions and multiple deductibles, but that doesn't occur that often. First 60 days, there's no copay with Part A. There's very few people that go beyond 60 days, but if you go beyond 60 days, the copays go up. It also will cover you for like rehab in a nursing home. The first 20 days, there's no copay, but you have to jump through a bunch of hoops to qualify for that. The first and foremost, in order to qualify that, you have to have been admitted as a patient for at least 3 days. And if you go to the hospital, you want to make sure you're admitted, not there under observation. That's a big thing to remember. Your doctors has to decide that, and it's got to be for the condition you were treated for in the hospital. Does this cover long-term care? No. Long-term care is custodial care. Medicare is medical care. So a lot of people say, well, what about long-term care insurance? That could cover you, but it's not the simplest thing to understand. I don't do that, but if somebody was curious about it, I could refer you to somebody that does. And then what about Medicaid? Well, Medicaid in Massachusetts is Mass Health. There's two types of Medicaid or Mass Health. The first one was your spouse needs to move into a nursing home, and you don't want to pay those costs. So there's a way to juggle your assets around so she qualifies and you can keep your stuff. And the other type is community care, which can help pay for care at home. In either case, you'll want to talk to an elder law attorney. That's what they do. I enrolled one in August into a Medicare plan. He just turned 65. And while I was explaining this to him, of which he knew, I said, Frank, you know what I tell people? I tell people, if they come to see you, it's going to cost them an arm. But they'll still have the rest of their body. And he said he thinks he's going to use that when he's talking to people going forward. What does A cost? Well, if you or your spouse paid into the system for at least 10 years, it's free. I've only had a couple where they had to pay close to $500 for, and these were conditions in which the kids brought mom and pop over from the old country. Mom and pop hadn't paid into the system, so they pay the higher amount. Original Medicare, Part B, if you turn 65 after January 2020, you'll have a $233 annual deductible. I'm a little past that, so I'm grandfathered. Actually, I'm a grandfather too. I have two granddaughters, 16 and 13, and my son is going crazy because these granddaughters have attitudes now. So I said, as though you didn't. So if you only have original Medicare, you're going to pay 20% of physician costs and outpatient costs. It's got to be medically necessary. It covers physicians, outpatient, an ambulance, DME. My oldest son has sleep apnea. He wears a CPAP. That's considered durable medical equipment. And some of my good friends told me I should be using the mental health benefit. You know, but I hit them back harder than they hit me, so it's, you know, come on. Part B has a premium based on your income. In 2022, it's based on your income for 2020. And what's your income? Your income is the modified adjusted gross income, which is on your 1040, it's line 11 plus any add backs. This starts out if an individual is making $91,000 a year or less, or $182,000 for a couple filing jointly. The cost is $170.10 a month. But if you make more, you pay more. Now I'm working with a husband and wife. He's 67, she's 66. They're coming off a group health plan, and they're each going to have to pay almost $600 a month. And they're really squawking, but he makes $1.5 million a year. So I think they can afford that. I retired last year. I'm not making the big bucks anymore. There are 8 life-changing events where Social Security will change the cost basis for what you pay for Part B. You got to contact Social Security, and they'll tell you what they need to prove that you can have that cost reduced. That's original Medicare, hospital and medical. Medical, again, is doctors and outpatient. Repeating, original Medicare is government insurance. Part A is free for most people, but it has a deductible for each benefit period. Part B, physicians and outpatient, is a premium. And if you only had Part B, you'd pay 20% of the other costs yourself. That's government insurance. So before we talk about Part C, I want to hit upon prescription coverage. It's private insurance. There's 27 plans in Massachusetts. It starts out with something which you've been used to. There are co-pays for different tiers. Tier 1, preferred generics, is the lowest. Many of these plans have a zero payment for Tier 1 meds. But as the cost goes, as the numbers go up, the cost goes up. And we've been used to that. However, Medicare then puts 4 coverage phases on top of these plans. And it starts out, there's a deductible phase. Once you get past the deductible, there's the initial coverage. Once past that, you're in the coverage gap. That used to be called the donut hole. And if your expenses exceed that and go up further, then you're into the catastrophic stage. Now, I don't want to sit down with anybody and explain that, because as you hit one, you're going to go back and forth trying to understand it. But if somebody wants to understand it, I can email them a video that explains these steps in detail. And if they promise me they've watched the video at least 3 times, now I'll talk to them about how these plans work. But the bottom line, they are what they are, and it is what it is. But there is some kind of rationale, a government rationale, that went into coming up with that. So you can get it 2 ways. You can just have a standalone plan to go with your A and B, or you can have it with the type of plan that I have, which is called Medigap. You still need the Part D drug plan. If you go on to the Part C or Medicare Advantage plan, you have to have both A and B. So based on your income, there's extra cost for Part D, but compared to Part B, it's kind of a little tap on the wrist. There's no $600 there, but that $77 at the bottom would be in addition to the almost $600. Always, always, always ask for generics. That doesn't happen all the time. If somebody has expensive meds, I send them to the CIPA website, which is the Certified Canadian International Pharmacy Program. They have 34 member pharmacies, and you all adhere to a high standard of ethics, and you can order prescriptions from Canada just by mail order like you would do here. The only thing not available by Medicare would be diabetes meds that require refrigeration. I was talking to one pharmacy up there. I said, why don't you tie 2 ice cubes around the prescription and send it in the mail? And I have to realize they've been rolling their eyes up in their head like, who is this guy? Now, this doesn't work in all cases, so it's catch as catch can. But if you got a very expensive drug, you might want to check that out. The other thing is, do you understand Good RX? Yes, no, maybe? In addition to the other stuff I've had, 6 years ago I didn't want to drive at night. The glare was too much. So I had cataract surgery. They do the eyes 2 weeks apart, but for each eye they gave me 3 different eye drops. Eye drop 1 cost $12, eye drop 2 cost $17, eye drop 3 was $84. $84 falls into the no way category. So I had heard about Good RX, so I went onto their website, plugged the name of the eye drop into that, and I got a printout and a barcode on it that I took to Walgreens, and the $84 shrunk to $27. So anytime you're grappling with expensive meds, even expensive meds in a Medicare drug plan, you want to check out Canada or Good RX. The state has a program to help people that need help because of their financial situations. No assets are required, but you can get different degrees of help from the state with incomes of up to approaching $60,000 a year. So it's there. The government came out with a plan calling a black horse white. They called that the Inflation Reduction Act. And in there, they showed what's going to happen with prescription drugs. So starting in 2023, the most a person on, for diabetes medications is going to pay a $35 copay. But it's a government constructed plan, and nothing happens overnight. So that same year they start negotiating the drug prices. And they don't cover all of them. They, first of all, picked out the top 100 Medicare drug plans people ask for. So they're initially going to pick the first 10 to begin negotiations with the pharmaceutical companies. They also said from 24 to 2029, you pharmacy people or manufacturers cannot increase your cost by more than 6% a year. Yeah, you got to wait a couple of years for that. Also in 2025, this is the best thing I think of the program. The maximum anyone's going to have to pay is $2,000 a year. So remember back in 2023, they started the negotiations. Well, in 2026, they'll have completed those, and those plans will cost less. And then in 2029, they'll have up to 60 more of those medications will take effect, the lower prices. But it's not going to happen overnight. And there's more fine print in this, but I mean, it is what it is. And these were what I gleaned from an AARP newsletter. Now let's talk about Medicare, the whole Medicare Advantage, which is A, B, and D. Some of these plans have zero premium, none, de nada. So how does that happen? Well, you got to understand everybody working has 1.45% of their income is taken out as a deduction. The employer matches that with another 1.45%, that's 2.9%. Let's call it 3%. So 3% of all the payroll deductions in the country go to Medicare to pay for Part A. The medical costs are what an individual pays for Part B, what an individual pays on a monthly basis. Now, these payments go directly to Medicare, for which Medicare really has unlimited claims liability. So let's say I'm Medicare. I want to get rid of that liability as much as I can. So I go out and I don't want to say bribe. I pay a subsidy to a private insurance company to provide you these benefits, and it starts off at $1,000 a month. So if you're turning 65, your mailbox is getting slammed with stuff that keeps coming and coming. And it's all of these insurers want the young 65-year-old kids who are in good health, because then they're making money hand over fist. But fast forward that 20 years, now they're 85 and they're starting to pay out money, but that's how an insurance pool works. These plans have to provide everything you get with Part A and B, and most of them include the drug coverage. And that subsidy allows them to offer some free stuff. Dental, vision, hearing, health clubs. And whatever they offer, it's because their actuaries have determined what they can offer and still remain in business. These Advantage plans are HMO or PPOs. HMO, everybody familiar with HMOs and PPOs? Now, there's 50 Medicare Advantage plans in Massachusetts. How does somebody find out which one fits them the best? So I say send us a list of the physicians you use and what meds you're taking. Now, I plug that into a very sophisticated insurance website, but a person could do this themselves on the Medicare.gov website if you can figure out how to work it. And then they'll print out what the costs are for all 50 plans with the least expensive one on top. So the next page is an actual printout I got. It showed the first 10 of the 50. And the plan on top was the ABC Insurance Company. I can't mention the actual company because then this becomes a marketing or sales presentation. The monthly premium in this plan was $0. This particular man, the husband, has a lot of meds, so his meds were figured out to cost him $800 a year. They have to pay up to $5,900 in their network before everything then becomes free. And some people will squawk about, well, I've got this $5,900, copay. I don't know many people that actually hit that. But the other side of the coin says if you were still on original Medicare, you would have unlimited liability. So it's a positive. The husband, his plan is going to cost him $814 a year. Well, he's going to have deductibles and copays as he sees doctors. But his wife had the same plan, and his wife was disgustingly healthy like my wife. I didn't shut that off. I apologize. Anyway, his wife had the same exact plan, and she has Tier 1 drugs with no copay, so she got the same plan for $0 premium. But if she got meds, she might have to pay more if she had to use them. All of these plans cover you for emergency care or urgent care anywhere in the country. So now we want to talk about the plan I have. It's called Medigap. Along with that, I need a separate drug plan. And the way these plans work is it covers every doctor in the hospital in the country that accepts Medicare. You need a separate drug plan with it. How does it work? Medicare pays first, then the Medigap plan insurer pays second, and again you need a separate drug plan. So, how does the bills work? The provider, the doctor, the hospital, whatever, bills Medicare. Medicare pays its share. And since Medicare knows that you have, or I have, this Medigap plan, after they pay their share, they then send the bill to my insurance company. And this was actually a bill I had, and ABC then pays the balance. Now, people want to know, what's the best Medigap plan available? Well, all these plans are identical. They all require a separate drug plan, and they don't cover prescription drugs. You need a separate Part D plan. The network, as I said before, is any provider that accepts Medicare. Customer service. Mine is the best. I'm having an argument with Renee. She says hers is the best. So, I don't care whether it's health insurance. Anytime you're calling customer service, you're calling an 800 number, usually. And who do you get to speak with? Whoever picks up the phone. And is that person having a good day or a bad day? So I know that anybody that calls mine is all having good days, but not necessarily with Renee. What about claims experience? Most claims problems occur from a billing error because the provider plugs in a code into the computer, and if they hit the wrong key, then that's when the claims problems could begin. So what I want to do here is pictorially highlight these three types. Original Medicare is Part A and Part B. That's it. But you need that as a ticket of admission to get the other plans. So, Medicare Advantage includes Part A, Part B, and Part D. And you get extra stuff from the insurance company, depending on what the actuaries say you can pay, or they'll pay. Now, the plan I have is Part A and Part B. I have to pay extra for a Medigap plan, plus extra for a drug plan. Now, like I said, my wife is disgustingly healthy. She sees her PCP twice a year for essentially a wellness visit and doesn't take any meds. So she's got a limited network. I've got a national network. And we live on the Route 20 end of the lake. All of her doctors are at UMass. So she doesn't care if her plan is called a limited network because it covers all of her doctors. She's got deductibles. If you turn 65 January 1920 or later, you got a small annual deductible for Part B. Co-pays for my wife, none for me. She'll need referrals, I don't. Lower cost or higher cost. Now I explain these two approaches or two options by, I call her pay-as-you-go. She has no deductible, but as she has visits and if there are any deductibles or co-pays, she's paying them as she go. Now I could have that same plan myself, except I'm a big user. And I may, over the course of the year, average 2 specialist visits a month. So the copay, if I'm on that plan she has, the copay for that is 45 or 50 bucks to see the specialist. That's 100 bucks a month. And these specialists are nosy. They want to run me through all kinds of tests, and I might average 100 bucks a month in tests. So yes, I can have her plan, a zero premium, but I know I'm going to spend 200 bucks a month on other stuff. So my option is to get this plan over here, and I might pay the same 200 bucks a month, but I don't have to worry about all the, paying for this and paying for that, because I just hand them my card and I'm covered. Both of these are going to have co-pays for prescriptions. So it all depends on what fits a person today. Now, if Linda's health tanked in the future, she could switch to what I have. So, and she could change her plan between October 15th and December 7th. Does it make sense with seniors who are still employed? They've got employer health coverage. Well, I'm the employer, and I've got 20 or more employees. I can't kick you off the health plan because you turned 65. I can't even bribe you to go off of that. So, there's always a workaround. So the workaround here is I want to educate my employees, or the retiring employees, on when they're transitioning into Medicare. I'm not forcing them to, I'm not bribing them to, I'm just going to say, hey, you're going to be retiring in a year or two, here's some stuff you should know. And what is it? It's the very same workshop you're seeing here, where the employees learn they might have other options. So they end up deciding whether they want to stay on the employer plan and leave it. And there's a couple of things that enter into that decision. Is what benefits are better, and how much are you paying, because the employer might be paying a big chunk of the cost. But that's something one has to decide once they have all the information. Where can you find answers? I think this young lady over here has got this book here. It's really a great resource if you know what to look for. So if you find what you're looking for, it triggers 3 or 4 more other questions, so you got to dig around to find out what that is. And I already talked about how your stuffed mailbox is, with the same people sending you the same stuff over and over again. And I don't know, would you buy a used car from Joe Namath? Joe Namath, J.J. What's-His-Face, and Captain Kirk are all pitching this plan that adds money to your Social Security check. Now, how does that work? Well, it's new in Massachusetts. It will really increase your Social Security check, but the insurer sends a fixed amount each month to your Social Security account. So, I'm making $2,000 a month from Social Security, and I got one of these plans, and I got the $70 one in Massachusetts, so they increased my benefit. But where did that money come from? Remember the subsidy that people get for being on the Advantage plan? Well, again, the actuaries determine whether or not they can have a give-back cost. One insurer now gives back $40 a month, the other $70. They're increasing it somewhat next year, and other insurers are going to be offering them, and we'll know sometime by mid-November who has what. The existing ones have limited provider networks. It's not a great choice this year, but they're increasing their network, so for 2023 it might be a better deal. And then there's a SHINE program. There's a SHINE Council here in the Senior Center. SHINE stands for Serving the Health Insurance Needs of Everyone. Now, the SHINE Council will probably say serving the health insurance needs of elders, but it's an option to go to a SHINE Council. They can explain the plans, enroll you in a plan. The challenge is can you fit it? Can your schedule match the counselor's schedule? And you've got to come here. I'll say that myself, I'll meet you at your home office or one of my many offices. You might think the thing down in the White City Plaza is Panera Bread, but it's my office. That's where I meet most of the people. And then the other choice you have here is the best choice. This guy here. And what I say to people when I throw that up there, you know, it's hard to be humble, but I'm doing the best that I can. So here's what one happy camper had to say. This guy was general counsel for a large corporation. He put me through every conceivable question. It was as though I was in a deposition. But that's how attorneys are. I also network with anybody that's dealing with elders, elder law attorneys, the whole list of things that are there. So if somebody says, when I'm meeting with them, you know, I need such and such, I say, I got one I can refer you to. And hopefully they're referring their people to me. I have the radio program. This is what an announcement could look like. And these are the ones I have scheduled. See, I had the schedule right here. It's 1 o'clock. But all these emergencies last minute. It always happens when you go on vacation. So what I start with, my first contact with a person, I'll send them an email with 2 Medicare.gov links. The first one will explain Part A and B, which I said before is also known as Original Medicare. And the second one will compare Original Medicare to Medicare Advantage. Now, if you're already on Medicare, I re-explain this. Are you on pay-as-you-go? Do you want prepaid? Or you want prepaid? Do you want to go to, you know, pay-as-you-go? You can switch the Medicare Advantage plan to a Medigap plan in the fall to be effective January 1st. The big thing to look for is if you're coasting along with Tier 1 or Tier 2 drugs, and all of a sudden you're getting a Tier 3, 4, or 5 drug, you might want to recheck your drug plan, because that could make a big difference. I've already discussed those. So the time for review is up to you. And the next slide is my favorite slide. That's all, folks. So you want to give me a shout? I don't have to, you don't have to, if you're getting a plan, you don't have to get it through me. But I want to become, right now I'm a secret agent. I want to become an unsecret agent. So I want everybody to say when somebody's looking for somebody to talk to about Medicare, I got a guy, this guy here. And I want this to go worldwide. So if you're on vacation over in Timbuktu, you're sitting at the bar, it's close to closing time, you're talking to the bartender, and you say, you know, my brother he's being frustrated, he's looking for Medicare. I want that bartender in Timbuktu to say, call Russ. End of story. Have you got any initial questions that you don't mind asking, you know, in front of others, or you can connect with me afterwards or give me a shout, whatever, but this is what I do.
I have a question.
Fire away.
So how does it work with Mass Health for people who qualify? And also, like, you have the health people who qualify for health safety net or partial health safety net and those things.
Yeah. All right. Well, there's, first of all, through Mass Health, which is Medicare, you can get a low-income subsidy. That's if you have Medicare. And the other one but Mass Health requires low income and low assets to qualify for. But you can still get help from meds with the state plan I mentioned to you before, Prescription Advantage. There's no asset test. So that's one way to get it. Now there's another way to get it if you have chronic conditions. They have a special needs plan. And again, you've got to have Mass Health coverage A, you've got to have that in order to apply for those. But if you know a person like that, they can get one of these special needs plans where everything is free, including dental coverage. Did I cover that? All right. Anybody got any questions? Okay, we got to go back to this slide here. My favorite slide. I love that slide.
Thank you. That's very good.
Thank you. You're welcome.